right, so what we have covered so far in the nervous system is we have traced and explained, I hope, why it occurs, the somatic innervation of every structure of every somatic, the innervation of every somatic structure in the body wall. And we have traced the innervation of every visceral structure in the body wall. And I'm pleased to say that Leonard Marshall, Marshall Leonard, are you here today? You are going to be asked to give us a lecture on the innervation of all the somatic structures in the body cavity. Would you get up and give us that lecture?
Want me to go to the front?
You can come to the front if you want. Marshall's doing innervation of all of the somatic structures in the body cavity, specifically the chest cavity. In somatic structures, all the somatic structures in the body cavity. Question I wouldn't ask you to do it.
So the simple question is that there is none.
Excellent lecture, better than the one I will be giving you, I guarantee you. There are no somatic structures in the body cavity, and that includes in the chest or thoracic cavity as well. Huh?
Body wall. Oh, body cavity.
I asked Marshall to give us a lecture on somatic structures in the body cavity. I gave you one on somatic structures in the body wall. All right, but his is probably more memorable. All right, so now we're going to be looking at a region of the body, the thoracic cavity today. We'll look at the abdomen and pelvis in a few days, where all of the structures within that cavity are visceral structures. And therefore, the only kind of motor innervation they get is visceral motor or autonomic motor innervation. Now, we did mention very briefly that there are two portions. I mentioned very briefly there are two parts of the autonomic nervous system, a sympathetic part, which we dealt with a bit, and the parasympathetic part. And we were able to ignore the parasympathetic part because none of the body wall visceral structures get parasympathetic innervation. But now when we're talking about the internal organs of the chest, and the same is true of the abdomen and pelvis, these get a dual innervation. They get some sympathetic innervation and some parasympathetic innervation. So we have discussed, let me say, the one overriding similarity between the parasympathetic and the sympathetic system is that in both cases, the cell body, whose axon goes out to the visceral structure, out to the smooth muscle or cardiac muscle or gland, that cell body lies outside the CNS. Now, I've already made that very clear for the sympathetic system, and now I'm making that statement equally clear for the parasympathetic system. Cell body lies outside the CNS. That is the overriding way in which these two systems are similar. However, they are quite different in most other ways. There are three categories in which they are different. One is, I don't know, for want of a better phrase, what they do. All right? The sympathetic system is largely concerned with promoting what I like to think of as energy expenditure. And the parasympathetic system is largely concerned with promoting intake and preservation, mainly intake and what? Absorption of energy. Now, to put this in some, hey, you can't read my handwriting, which is why it's good the PowerPoint came along, right? What sort of things are involved in the expenditure of energy? Your heart rate gets more rapid, all right? Your pupils dilate. Your blood vessels to your muscles dilate. And we could go on and list other things. Equally important is that in order to direct blood to your heart and to your muscles and things like that, your bowel gets slowed down because you don't want to waste it sending blood and oxygen to parts of the body that are not going to be used in rapid expenditures of energy. The parasympathetic system is just the opposite. It causes your bronchi to constrict because you don't need so much air. This is a complicated issue about bronchi I'll mention later. But it causes your heart to slow down. It causes your coronary vessels to constrict. It causes your bowel to actually become much more active because intake and absorption of energy is done by the bowel. It also, you cannot bring in any energy and absorb it unless you dispose of waste. You have to dispose of waste to make room for new food stuff. So the parasympathetic system is involved in defecation. It's involved in urination. Anything that allows you to get rid of waste and bring in new energy-producing substances, it is promoted by the parasympathetic. Now, a lot of people like to think of the sympathetic system as the fight or flight system. And that is true, because fighting requires lots of energy expenditure, and fleeing requires lots of energy expenditure. The only reason I don't like to do that myself is because those two words, flight and fight, are very similar to the word fright. And when you are frightened, your whole autonomic nervous system discharges. The defecation and urination, when you are scared to death, is not sympathetic. It is parasympathetic. So I don't like people to confuse and think fright is part of that. So to me, it's just promoting energy expenditure, sympathetic, promoting energy intake and absorption, getting rid of waste, parasympathetic, and I just try and deduce every function on an organ in that way. There is one, I guess, exception to this rule that at least I haven't been able to fit into this rule, and that is erection, penile erection, and I presume clitoral erection too, but penile erection is more important in the procreation scheme of things. Penile erection is brought about by the parasympathetic nervous system. Is that energy absorption, intake, or waste disposal? I consider sperm waste, I guess it is. But actually that's wrong, because penile erection is by the parasympathetic system. Ejaculation, which is the sperm shooting out and the semen shooting out of the penis, is done by the sympathetic system. I cannot fit that into the scheme. So in this case, I actually, of course I don't have to use this, but there is a mnemonic device, and I'm going to write this word down, mnemonic. Mnemonic is a word that means relating to memory. And a mnemonic device is one that helps you to remember things. You will end up using a lot of these things for names of wrist bones and stuff like that. Once you've learned your anatomy well enough, you don't need to use those. I want to point out to you that this word is mnemonic, not mnemonic. Mnemonic, P-N-E-U, M-O-N-I-C, is a plague, the pneumonic plague. That's your lungs. You laugh at this. The fact is, 5-6 years ago, there was a paper published in a journal of family medicine in which the author recommended a mnemonic device to help people remember something. And one of my own students wrote a letter to the editor saying that this was foolish and this journal should know better than to use the wrong word for this. And if I catch anyone in labs saying mnemonic when they mean mnemonic, then I'm usually extremely rude to them. So, but the mnemonic device for remembering the difference between the parasympathetic and the sympathetic nervous system with regard to the penis is point and shoot. Pointing being the erection done by the parasympathetic nervous system, shooting being the ejaculation being done by the sympathetic nervous system. All right, so One of the differences then between the parasympathetic and sympathetic is the effect that they have on the different organs that they co-innervate. The second difference is where the preganglionic cells lie that control the cells that are outside where the preganglionic cells lie. You know that many sympathetic preganglionic, I shouldn't say many, I better say all because it's true of all. All of the preganglionic sympathetic cells, actually let me ask someone. Dov Beckhofer? I know who you are. Where do all of the preganglionic sympathetic cell bodies lie? You were told this in a lecture.
Sorry?
Where do they all lie? All the preganglionic cell bodies of the sympathetic nervous system. They all lie in a easily described location. Ask someone to your right or someone to your left.
Paravertebral ganglion.
Wrong answer. His answer was paravertebral ganglion. Who would like to give me the right answer?
T1 to L2.
T1 to L2 of the spinal cord, specifically what part of the gray?
Part of the gray.
What part?
White matter.
Now, what? Huh?
Lateral horn.
Lateral horn. I accept that. Okay. All right. So I tend to use the word intermediolateral column. I accept lateral horn. So the intermediolateral column in the spinal gray between T1 and L2 inclusive. That's where all the preganglionic sympathetic cell bodies lie. The parasympathetics don't lie there at all. They all lie either in the brain itself, the brain stem, the medulla, and the thing that's in front of the medulla, midbrain, all right, and things like that, which I can hardly remember. They all lie in the brain stem, or they lie in the sacral 3 and 4 segments of the spinal cord. In a region, if I were to draw a cross-section of the third or the fourth sacral region of the spinal cord, it in fact would look a lot like everything we've already seen. Again, the beauty of PowerPoint, it looks nice if I, oops. There is no intermediolateral column in this butterfly-shaped gray region. On the other hand, at a site where the intermediolateral column would be, if it were there, that is, at a site at the lateral edge of the spinal gray, between the dorsal horn and the ventral horn, are located parasympathetic preganglionic cells at the S3 and S4 levels of the cord. You will probably read in other books S2, 3, and 4, although the person who I trust on this most said that it's some people S2, not everybody S2. Some people S5, not everybody S5, but in everybody S3 and S4. So those are the numbers that I want you to know. If you just accept the fact there's human variation, some people it's going to be S2, 3, 4, some people S3, 4, 5. You'll be fine. So they lie either in the brain or in this comparable region of the spinal gray to the intermediolateral column, even though there's not a real bump there, at the S3 and S4 levels. For this reason, in fact, the sympathetic nervous system is often called the thoracolumbar portion of the autonomic nervous system, and the parasympathetic nervous system is often called the craniosacral portion, to illustrate the difference in where the preganglionic cell bodies lie.
Dr. Stern,
Let me just erase this, and I'll turn around and answer your question. Yeah.
can you just repeat for me that there is no intermediolateral column in S2, S3?
Repeat it for you because you just said it and it's true.
You know what I mean?
Confirm it.
Is that what you said?
I said there is no intermediolateral column at S outside of T1 through L2. There's no intermediolateral column.
Okay.
What there is at S3 and S4 is a zone between the dorsal horn and the ventral horn that contains these preganglionic parasympathetic cells. So they're not so different in position. They just don't bump out and make a column, a recognizable gross column that you can see there. And then the final difference, I probably don't have to write down, is where the postganglionic cell bodies lie. Now, you know where quite a few of the postganglionic sympathetic cell bodies lie. Quite a few of them lie in the paravertebral chain. You will learn in the lecture on autonomics of the abdomen and pelvis that there are other sympathetic ganglia in the body, or in the abdomen, that are not part of the paravertebral chain. You'll learn about it later. These sympathetic cell bodies tend to lie in easily dissectable and visible ganglia, paravertebral or the ones we'll learn about later in the abdomen. Parasympathetic cell bodies lie in a few dissectable ganglia in the head. We'll see those when you dissect the head. But for anything below the head, parasympathetic cell bodies do not lie in dissectable ganglia that you can see with the naked eye. In the vast majority of cases, parasympathetic cell bodies actually lie distributed in the wall of the organ to be innervated. So they are distributed in the epicardium of the heart. And we don't see anything resembling a ganglion. They're just, if you have a histological section of the heart, in its outer wall, just in the fat there, you can find parasympathetic ganglion, postganglionic cell bodies. They are distributed throughout the length of the bowel within it. They're in your urinary bladder. They're in the wall of the organ to be there, in the bronchi of the lungs, distributed in the wall of the organ to be innervated. So these are all pretty different sorts of ways that these two systems are organized. Yeah.
I heard that if you're below the diaphragm, it's not into the wall of the organ, it's close by.
All right, you're Henna, right? Henna says she heard that if you're below the diaphragm, it's not in the wall of the organ, the parasympathetic cell bodies, but close by. Why? Who did you hear that lie from? Well, the TAs told you wrong, and the TA should read the chapter in Core Concepts dealing with this, that TA. They are in the wall of the bowel. They're in the wall of the bladder. They're in the connective tissue within the liver itself, or within the pancreas. They're in the organ itself. There are a few non-dissectable parasites. Well, I mean non-dissectable. I mean, you can't see them with the naked eye, but if you go in with a microscope and you do a dissecting microscope, there are a few in the pelvis that are actually outside the wall of the organ. But I tell you not even to think about those. That's just an extra added fact that's just going to bother you to think about. You should think about them all as being in the wall of the organ for everything below the head.
So are they still considered to be ganglia?
They are called ganglion cells. They're called postganglionic cell bodies, even though they are not part of a ganglion. That's right. Well, we already know that the postganglionic cell bodies of the sympathetic system should really be called ganglionic cell bodies, but they're not. These are called postganglionic cell bodies by analogy to the sympathetic system, even though they are not part of a dissectable ganglion. Yes?
Do the preganglionic axons need to migrate in the parasympathetic nervous system the way they do in the sympathetic?
Migrate meaning?
Migrate as in when above T1 to the cervical or in the sympathetic?
Well, you have the only source of preganglionic, well, let me talk about the preganglionic. The answer is no, but I'm not sure I understood the question completely but we'll talk about the preganglionic. We'll talk about the parasympathetics of the chest now, and if you still have that question after that, and after we have the abdomen and pelvis lecture, come and see me.
So I got that the parasympathetic postganglions are in the walls of the organ.
The cell bodies, the postganglionic cell bodies are in the wall of the organ.
What about for the sympathetic again?
The sympathetic tell me a place where some sympathetic...
I have no idea.
No, you have to know this. You have to know this. Come on.
I'm on the first.
So, here, fellow who's staring at me with hatred in his eyes. The one who just turned around, right. In the gray shirt. Tell me some place where postganglionic sympathetic cell bodies lie. Some place, any place.
Postganglionics?
Postganglionic sympathetic cell bodies.
In the vertebral femurs?
Right, the paravertebral ganglia. There's a whole slew of them in the paravertebral ganglia. There are others in a different set of ganglia in the abdomen that I mentioned very briefly here, which we'll talk about next time. But there's a whole slew of sympathetic postganglionic cell bodies in the paravertebral ganglia. All right. What am I talking? So, now, craniosacral, remember? Parasympathetics, cells, preganglionic lie in the brain or in the sacral regions of the spinal cord. We're not interested in those that lie in the sacral regions of the spinal cord today because those are just for pelvic structures. So today we're interested in the innervation of the chest. In all of the preganglionic cell bodies that give rise to parasympathetic preganglionic axons for the chest, they all lie in the brainstem, and all of those preganglionic parasympathetic axons exit through one nerve, the vagus. So the vagus carries all of the preganglionic parasympathetic axons for organs of the chest. Some of you have seen a bit of the vagus in dissection already. It leaves the brain. It travels down the neck. You'll see that when we do the neck. In the neck, the vagus gives off some branches which are called vagal cardiac branches. When it gets low, and I'll trace those in a moment, after it enters the chest, it goes and participates in a formation of something called the pulmonary plexus on the posterior, largely on the posterior posterior aspect of the main stem bronchus that goes to the lung. And the vagus then leaves the pulmonary plexus and participates in something called the esophageal plexus on the surface of the esophagus. So the pulmonary plexus is what the preganglionic parasympathetics for the lung are going to pass through. They're going to go to this plexus and then distribute out to the bronchi of the lungs. The esophageal plexus is where the preganglionic parasympathetics for the esophagus are going to emerge and go to the esophagus. But of course, the most important structure in the chest is the heart. All right? You can live without an esophagus if you just bring your stomach up to your throat. It's done for people who have esophageal cancer sometimes. It's hard to live without both lungs. It's pretty darn hard. But you can live without one of them, but you can't live without your heart. Well, now you can because they have, mechanical things. So, but still, the heart is, I digress. All right. The heart is still the most important structure in the chest. So within the neck, usually, are these vagal cardiac nerves. And some of them are actually given off by the vagus when it enters the chest, but before it takes up residence on the posterior aspect of the main stem bronchus. So there are a bunch of these vagal cardiac nerves, some in the neck, some in the chest, and they all converge on a site just superior to the bifurcation of the pulmonary trunk. And that site is called the cardiac plexus. And it is where the vagal cardiac branches from the left vagus and the vagal cardiac branches from the right vagus converge, and where the sympathetics, which we'll talk about later, that are going to the heart will converge. All right? And there's this plexus of nerves. Plexus just means interweaving of nerves on the superior aspect of the pulmonary trunk. And then from that, the preganglionic parasympathetics that have been brought to it by these vagal cardiac branches just travel down the ascending aorta and the pulmonary trunk to go to the heart. And in the wall of the heart, they will find their postganglionic cell bodies on which they synapse. And then the postganglionic parasympathetic axons are very, very short. They're microscopic in length almost. because the cells are sitting right next to the heart muscle and right next to the coronary vessels and don't have to send long axons to get there. All right? This is the parasympathetic innervation of the chest. From the pulmonary plexus, preganglionic parasympathetics distribute along the bronchi, and within the walls of the bronchi are the postganglionic cell bodies. From the esophageal plexus, preganglionic parasympathetics enter the wall of the esophagus, and within the wall of the esophagus are the postganglionic parasympathetic cell bodies. So it's a system which has long preganglionics and short postganglionics. All right, and that's it. There's nothing more about the parasympathetic innervation of the chest that you can talk about. So now let's talk about the sympathetic innervation of the chest. And for that, we will return to our friend PowerPoint. Anybody fail to understand that the vagus is the parasympathetic supply of the chest? No.
Professor,
Yeah.
I do have one question. Can you explain a little bit of what the purpose of a plexus is? I'm not really sure.
A plexus is where fibers from different nerves tend to meet one another, sort themselves out, and then go to the places they're supposed to go to. It's fibers from the left vagal cardiac and the right vagal cardiac branches meeting sympathetics that we're going to be talking about here, and then they just meet and they just turn in, and from the plexus emerge usually a smaller number of nerves taking the relevant axons to the place they're supposed to go to. I can't think of it any other way than that.
Is it almost analogous to like a ramus?
No, a plexus is an interweaving of nerves. It's a whole bunch of nerves converge in one place. They all crisscross and mix up and then leave it and end up going to where they're supposed to be going.
So the vagus nerves that come out from the brain and they go into that plexus?
Now, the vagus comes out from the brain as a single nerve. It gives off vagal cardiac branches, which mix with sympathetic cardiac branches we'll be talking about in this cardiac plexus. And then from that cardiac plexus, the vagal and sympathetic cardiacs travel to the heart in bundles where they're together.
And there's a left and a right.
The cardiac plexus is fed by the left vagal branches, which are numerous, really 4 or 5, and by the right vagal branches, which are numerous. Then the vagus itself, however, goes down. You'll trace it onto the posterior aspect of the bronchus, where it mixes with sympathetics to the lungs in what's called the posterior pulmonary plexus, and then from that goes things that enter the lungs itself. And then you won't see that as much as you'll trace the vagus on the back of the bronchus.
Just practically, does that allow for like synchronization of if you need to increase your breathing, then your heart rate also increases? No, it doesn't.
No, there's no crosstalk at all in these plexuses between the nerves. None at all. I mean, you could have every single vagal cardiac branch go to the heart independently of every other one and independently of every sympathetic. I mean, this must have to do with it's a non-functional thing in a way, I guess. It must have to do with the positional information in the embryo that is guiding these nerves. And they're all sort of being guided towards the heart. They're all being attracted to this one spot. And when they get there, then they're guided directly to the heart. But as these things get attracted to one spot, they just interweave with one another. And so in a way, it's maybe a developmental side effect. It does not have any real functional consequence. They don't talk to one another there. All right, here we go. This is something we know because this is a section of the spinal cord taken anywhere between T1 and T5. I guess the sample section I showed you in the last lecture was taken at T6, but it'll look the same anywhere between T1 and T5, and anywhere between T6 and L2 for that matter. And here are the sympathetic preganglionic cell bodies in the intermedial lateral column or in the lateral horn. Here they are passing out through the ventral ramus, the spinal nerve sensu stricto, white ramus communicans, into the paravertebral ganglion, which is a sympathetic ganglion, and synapsing on, illustrated here, only one postganglionic cell body, which then distributes to the dorsal ramus and the ventral ramus, and that is our body wall pathway. All right, our body wall sympathetic pathway. On thing. How about the heart? All right, I'm mainly going to talk about the heart, but what I'm going to say is equally true in a way of the esophagus and the lungs. All of the sympathetic innervation to organs of the chest, be it the heart, be it the bronchi, and I urge you to read the clinical sidelight on innervation of the bronchi, because it's more complicated than I'm going to say here. All right? And in fact, I modified it a little, so you might even want to go online and read the clinical sidelight to the modified version, to the modified clinical sidelight for innervation of the bronchi. But this will be true before bronchi, for esophagus, for heart, for any organ of the chest. All of the preganglionics lie somewhere in the T1 through T5 region of the spinal cord. So that part of the spinal cord not only has to be concerned with providing body wall innervation to the body wall segments above T5, but also is concerned with organs of the chest. The preganglionic sympathetics for organs of the chest lie in the intermediolateral column between T1 and T5. Also, the postganglionic cell bodies for every organ of the chest lies in the paravertebral ganglia, one of the ones between T1, well, not only, lies in the paravertebral ganglia. Certainly all of the paravertebral ganglia between T1 and T5, both on the left side and the right side, contain not only cell bodies that are going to be concerned with body wall structures like these two green ones here, but will have within these ganglia also cell bodies concerned with organs of the chest, esophagus, bronchi, and lungs, and esophagus, bronchi, and heart being the important ones. And the nerve, which runs straight from a ganglion to the organ involved, in this case is called a sympathetic cardiac nerve. So you will see, when you dissect, if you look carefully, though we don't ask you to see, from every one of the upper 5 thoracic paravertebral ganglia, both on the left and on the right, you will see these nerves which are not running to join a ventral ramus, but because the ones that run to join the ventral ramus are for the body wall, and those all come off the posterior aspect of the paravertebral ganglion. But you will see other little nerves coming off the anterior aspect of the T1 through T5 paravertebral ganglia, which are running to the cardiac plexus or to the esophageal plexus or to the pulmonary plexus. So I've drawn one called a sympathetic cardiac nerve, which is going to the cardiac plexus, but there are sympathetic pulmonary nerves, there are sympathetic esophageal nerves. These are controlled by cells which lie here in the intermediolateral column between T1 and T5, which travel out through the ventral ramus, the spinal nerve sensu stricto, ventral root, should have caught myself, ventral root, spinal nerve sensu stricto, ventral ramus, white ramus communicans. So far they're behaving just like the body wall ones. But when they synapse on this cell, things change because the postganglionics travel in direct branches from the ganglia to the organ involved. Now, this is just put in English, for all internal organs superior to the abdominal diaphragm. Everything in the chest, meaning. The involved paravertebral ganglia are T1 through T5, but also the 3 cervical sympathetic ganglia, meaning this. Some of these preganglionics that travel out, that are destined to control organs in the chest, do not synapse in the ganglion to which they are first brought, but rise and go up to the inferior cervical ganglion. Some go up to the middle cervical ganglion. Some go up to the superior cervical ganglion. And from those cervical ganglia come cardiac nerves, which then run down from the neck back into the chest, right next to the vagal cardiac nerve. Silly. Yes, you're looking at me like this is silly. And it is silly. All right? You know, the heart starts out in the neck when you're in development and migrates into the chest. So I'm sure it's related to this fact. So it is not. So what you've got is a case not terribly dissimilar from the body wall. All of the preganglionic sympathetics start in T1 through T5. They all go through the T1 through T5 ventral roots, spinal nerves, white rami. They're all brought to the T1 through T5 paravertebral ganglia. Some synapse in those ganglia, some ascendant synapse. And therefore, from all three cervical ganglia on each side and from the upper 5 thoracic ganglia on each side, not only come gray rami, but also these things which are called sympathetic cardiac nerves. Let's just trace the sympathetic innervation of the heart, the most important structure. All the preganglionics lie in T1 through T5 gangliomedial lateral column. They all pass out through the ventral root. They all go into the spinal nerves sensu stricto. They all enter the T1 through T5 ventral rami. They all go in the T1 through T5 white rami communicantes, and that brings them to the T1 through T5 paravertebral ganglia. Some synapse. But some do not synapse. Some pass through this to go to the inferior cervical ganglion where they synapse. But some don't synapse there. Instead, they pass through the inferior cervical ganglion and synapse in the middle. But some don't synapse there. They go all the way to the superior where they synapse. And from the upper 5 thoracic and the inferior, middle, and superior cervical ganglia come postganglionic axons, green, which, if they come from the thoracic ganglia, travel in things called thoracic sympathetic cardiac nerves. And if they come from these, are called cervical sympathetic cardiac nerves. These are postganglionic sympathetics. They all converge on the cardiac plexus, where they meet vagal cardiac nerves, which are preganglionic parasympathetic. And from the cardiac plexus, you then have postganglionic sympathetics and preganglionic parasympathetics going to cardiac muscle, coronary muscle, and the SA and AV nodes. That is now the complete innervation of the heart, and you can modify this appropriately for now. This is fine if this is all you know about that. All right. It's not fine. I thought I was going to show another slide here, but I'll show this one. What do we know about sensation from body wall visceral structures, meaning blood vessels? What path? Are you Bennett? Bennett. Are you?
Oh, I'm not.
You're not Bennett. Well, then who the hell are you? Huh?
I'm Ping.
Ping?
Ping.
All right, Ping. What do we know about sensation, visceral sensation, which as we know is uncomfortable or painful, from body wall visceral structures? How would you describe the pathway that it follows?
They follow the exact opposite pathway.
Excellent. They follow the exact opposite route of the sympathetic. Same for all of the structures of the chest as well. In fact, same for everything in the body. So if I want to know about what tells me if I've had a heart attack or not, which is ischemia of my heart muscle, there will be a receptor in the heart muscle which is sensitive to low oxygen. That will start to fire the sensory axon, and that sensory axon will go into the cardiac plexus. Will then, there's many of these sensory axons. Some of them will travel in the cardiac nerve coming from the inferior cervical ganglion. Some will turn into the cardiac nerve coming from the middle cervical ganglion. Some will turn into the cardiac nerve coming from the superior cervical ganglion. And some will travel in the cardiac nerves coming from the thoracic, upper 5 thoracic, paravertebral ganglia. They will reach these ganglia, all the 3 cervical and the upper 5 thoracic paravertebral ganglia. But these are sensory axons, and as you know from the email I sent, they don't synapse in any of these places. They just turn and run the opposite direction to the preganglionics that were coming up the ganglia. So they all are brought back down eventually to the upper 5 thoracic. And from the upper 5 thoracic now, they're all converging on these ganglia, either having descended from cervical or having been brought straight to upper 5 thoracic to thoracic sympathetic cardiac nerves. And from then, those sensory axons enter white rami communicantes, enter the ventral rami of the spinal nerve, enter the spinal nerve sensu stricto, and only at this point do they deviate into dorsal roots, where they find their cell bodies in the dorsal root ganglia, and the central processes go and synapse in the dorsal horn of the spinal cord. So it's just exactly the reverse route of the sympathetic pathway. That's all you need to know an awful lot. Now, this is what I thought the next slide would be. This guy was a guy who's the last guy I know to ever thoroughly dissect the autonomic nervous system. In 1970, he wrote a book about it. It's phenomenal. A classification of middle and inferior cervical, vagal, and sympathetic nerves appears to be entirely arbitrary and meaningless after I just gave you this lecture, because of the admixture of vagal and sympathetic fibers in the same nerve bundle and their variability in origin, disposition, and anastomosis with adjacent nerves. In other words, I've told you that there are vagal cardiac nerves from the vagus and the neck. And I told you that there are cardiac nerves coming from the sympathetic ganglia in the neck. But in fact, the axons all tend to join one another. And the things which drop down from the neck are derived both from the vagus and from the sympathetic ganglia. You can't really trace the sympathetic ones individually to the individual three cervical ganglia. It's just a big mess. So what you do is if you see, here's the bottom line. You see any nerve in the neck that's coming down into the chest that you cannot give a name to, it is a nerve that's probably carrying both vagal and sympathetic axons heading for the cardiac plexus. I don't care if this may make it harder for you to learn, and then if it does, forget it. If you like to think of the vagus having distinct branches to the cardiac plexus and the sympathetic ganglia having distinct branches and they're forever separate until they meet in the cardiac plexus, fine. It's just that they join one another a lot, and therefore that's what this guy was saying. The sensory, I should have put that earlier. The sensory innervation, all right, we've traced it backwards. It all travels backwards along the sympathetic route. There's no sensory innervation from the heart that travels backwards along the vagus. It all travels backwards along the sympathetic pathway. That means it's all brought to T1 through T5 of the spinal cord, where those where those visceral afferent or visceral sensory axons synapse on cells of these viscerosomatic gray columns that we talked about. Now they tend, as a visceral sensory axon enters the spinal cord, it splits generally and sends a branch up the spinal cord and down the spinal cord and synapses in the dorsal gray over a fairly large extent. A somatic sensory axon, when it comes into the spinal cord, tends to synapse only at the level that it's first brought to. That's why you have very good localization of somatic pain, because it only synapses at one spinal cord level. And you have very poor localization of visceral pain, because the visceral axon enters the cord, splits, one branch travels up, one branch travels down, it synapses as multiple levels going up and multiple levels going down, and the spinal cord doesn't really know where the pain is coming from. And that's why visceral pain is so poorly localized, because of the way these pain axons travel in the spinal cord. The fact, however, that these cells, let me see what the next slide says. Yeah, the fact that these cells will get both somatic sensory axons synapsing on them and visceral sensory axons synapsing on them means that right off the bat the potential arises for you not knowing which is the real source of the disease or pathology. Your brain is pretty good usually, because it knows that if the region of spinal cord that's been stimulated is long, it's probably a visceral pain. If the region of the spinal cord that's been stimulated is localized, it's probably a somatic pain. But it doesn't always make the correct decision. And as a result, visceral pain is sometimes mistaken as coming from a somatic structure. And you feel pain in that region of the body wall that is innervated by the same spinal cord segments as innervated the internal organ. In other words, if you have pain arising from your heart, which is all returning to T1 through T5 of the spinal cord, that's a visceral pain, And the visceral pain you feel is a vague discomfort in your chest or pressure in your chest. You may also feel a very sharp, localized pain in the T1 through T5 regions of your body wall. Because the spinal cord, then feeding up to the brain, has mistaken where the source of pain is. It is mistakenly says, I don't know whether it's my body wall that's been damaged or it's my heart that's been damaged. So you're going to get pain from both places. Pain from an unaffected region of the body wall, innervated by the same spinal cord segments as an affected internal organ, is called referred pain. The part of the body wall is perfectly healthy. It is perceived as being painful by a mistake occurring as the brain interprets what's happening in the spinal cord. So you can generally figure out where the referred pain of a heart attack will be because you expect it to be in the T1 through T5 body wall region. Now, this is what's in all physical diagnosis texts published in 1985, probably not so many today. This is the typical pattern of referred pain from a heart attack. This is the T1. There's a little spread beyond T1 through T5, but it's mainly centered on the T1 through T5 body region of the body wall, and predominantly on the left side for reasons which are a little harder to explain, actually. This is the distribution of T1. Your T1 innervates your upper arm. So if a person comes in and says, my God, I feel this real pressure on my chest, and also, you know, it's hurting down the inside of my arm like that, man, that is just absolutely, you know they've had a heart attack, all right? It doesn't, this is the most common pattern. There may, and if you want to know, well, I won't do it, we'll just leave it at that. Sometimes, if it's very severe, you'll get it on both the right and the left sides. Sometimes it doesn't follow these things because I just wish, you know, just that these things are not they just don't always do what you want them to do. It's just that simple. You get a lot of times you get pain in the jaw. That's pretty hard to explain, really, on the basis of the anatomy of this region. I would not be surprised if some of these visceral pain fibers ascended actually to the cervical region of the cord in synapse. But why would you have pain just localized to the jaw and not in all the intervening segments, I cannot explain. And sometimes it's down here in the upper part of the abdomen, and sometimes it's in the back. These are considered uncommon, really. This is the most common. Now, having said this, referred pain you should deduce as going to the same regions of the body wall as innervated by the same spinal cord segments that did the organ you're looking at. We'll see this for some other organs later on. This is true of men. Women with heart attacks, and I don't know why this is, I've never heard an explanation for it, and it's only become popularly discussed in the last 10 or 15 years. Women with heart attacks often don't have any referred pain like this. And often they don't even have the crushing pain that you associate with cardiac ischemia. Women are described as coming in, you know, sick to their stomach, nausea, vomiting. This is considered one of the reasons that many women with heart attacks are misdiagnosed and sent home from emergency rooms with gastrointestinal disorders. I know of no anatomic explanation for it. So I'm giving you things that can be explained anatomically. But when you, what? But you're starting sick to your stomach and not feeling well?
No, I said greater pain tolerance.
Yeah, you know, I do believe women have greater, I believe they have greater visceral pain tolerance. But I didn't, so when you are learning about how to treat, how to evaluate someone coming to the emergency room, you cannot say, well, if you don't have a crushing substernal pain and pain down the inside of your left arm in a woman, you're fine, go home, because it may not be true. All right. When a man, though, you're pretty safe. Say, what the hell? Who cares? Go home. And if a man dies, who cares anyway?
So, it's been described that in ischemic pain of the heart, you can also have.
You're an EMT, right?
I was paramedic.
Paramedic, right?
No different.
All right. I didn't know there was.
Of course.
Here, wait. You're going to say something. You're going to say something.
Well, don't know if it's going to be useful, but so there are multiple case reports, and you hear about it frequently. It's even described clinically that you can have these kind of GI upsets and even hiccups in the setting of myocardial ischemia. Now, I have heard it, and I don't know if this is spurious or not, but that this is typically associated with inferior wall MI or distribution of the right coronary artery as opposed to left. Now, I've never understood what the possible neurological pathways would be that could explain this phenomenon, but it's been, I've heard people say things like, well, it creates local inflammation that causes diaphragmatic and, irritation, which causes hiccups or something like that. But again,
No.
can you make any sense of that?
Yeah, no. And the answer is no, I can't make any sense of it. Interestingly, this part of the jaw is generally done by C2 and C3, the skin over this region of the jaw. C3, 4, and 5 do the diaphragm. I don't know if there's any link there. So the bottom line is we can learn the anatomy of this. But when you actually get into clinical practice, it's a much more complicated situation than you would deduce solely from the anatomy of it. And now the question is, do I have any more? Oh, yes. There's one other thing I wanted to say. This one. And that's this. In terms of something that actually can be done if you know the anatomy of this, is a procedure that I think is discussed in clinical sidelights. How can you help a person? Angina is a recurring pain coming from ischemia of the heart, which is not bad enough to cause a heart attack. I mean, you over-exercise in a person whose arteries are atherosclerotic, and you over-exercise, the heart doesn't get enough oxygen, you start to feel a pain in your chest usually, and you stop doing what you're going to do, and then the pain goes away. So that's what angina is, as opposed to a heart attack, which is a dead part of your heart, all right? Because the ischemia lasted long enough and you didn't stop doing what you were doing, or occurred for another reason altogether. A clot was thrown out and you couldn't do anything about it anyway. People who have angina are generally treated nowadays with angioplasty or bypass surgery. Right? You just improve the blood supply to the heart, and the person's angina, if they're lucky, goes away. Some people, because of previous surgeries or for other reasons, are just not good candidates for either bypass or angioplasty. There is a technique that has been done. It's not widely done. And what it is taking out the T2 through T5 paravertebral ganglia, going in at surgery and simply removing the sympathetic chain between T2 and T6, pulling it out on both sides. You can do this endoscopically. You don't have to open up the chest to do it. And when you do that, you can deduce at any rate, boy, if I take out the T2 through T5 ganglia, I'm taking out 80% of all of the visceral sensory axons coming back from the heart. The only ones that are still there are the ones which traveled in the T1 ganglion. And there's a really good reason you don't take out the T1 ganglion that you'll learn about when we study the head. And this thoracic sympathectomy is actually effective in people who have angina that cannot be treated by the standard method, of reducing the number of episodes of angina they have, and in fact allowing them to exercise longer before they get an anginal attack. So it's not commonly done, but at least it's something that can be explained on the basis of the anatomy that I talked about today and why it should work. So that's how I want to close. Okay.